In my presentation, I will talk about the fixed varus equinus foot. We are talking about the patient, most of the time young patient after traumatic brain injury, or some other patient with common comorbidity like myelodysplasia, hereditary motor and sensory neuropathy like the Charcot-Marie-Tooth, or neuropathic disease like the Charcot foot. And in my presentation, I will talk about the foot in which a previous non-surgical treatment, like the injection of botulinum toxin and the progressive cast, make no result on the foot. We are talking about the foot in which during the operating room, after general anesthesia, you don't have any kind of correction after the reduction of spasticity. And for the treatment of the fixed equinovarus foot, there are different surgical techniques that, apart from the just soft tissue release and tendon transfer, and because there's a fixed deformity, you have to take care of the bone, and so you can make the triple arthrodesis, the ankle arthrodesis. You can use some device like external fixation, or some big aggressive surgery like the talectomy and ankle fusion. In my presentation, first of all, I will talk about my experience during last 20 years of experience. I'm an orthopedic surgeon. I just work with a neurologic patient. And so I have the opportunity during the year to do a lot of experience on this kind of problem. And taking care about neuroorthopedic patient, most of the time you have a foot like that, in which not only with soft tissue surgery you can solve the problem. So I have tried in the year to make different kind of surgical approach. Most of all, we are surgeons, so we can use different type of incision, scar, and Z-plastic. I start with a patient just with percutaneous Achilles tenotomy, flexor to release, the tibial posterior lengthening. But in some cases it wasn't enough because the skin on the medial aspect of the foot was retracted as a soft tissue, and so we have to complain about the correction of the skin. So this was my first experience. So it's a big surgeon with a lot of scar and with different problem for the healing of the scar. And then I move toward the biological tissue and the skin graft. I use the biological tissue, and then after 10 to 1 week, 10 days to 1 week with the skin graft. Again, with the biological tissue and skin graft, you can correct a big defect of the skin, but again, you must follow the patient. It's difficult to put a plaster because you have to avoid to cover the skin, and so it was difficult to treat the patient after the surgery. Other experience was done with my plastic surgeon colleague with free flap. As we can see here, with a big incision from the posterior to medial aspect of the foot, you can correct everything. You can lengthen the tendon, you can open the joint, you can make a good reduction of the foot. But after that, you have to cover a great defect of the skin. So we move with the free flap. This one is a free flap from the iliac. It's a halt anterolateral tight free flap, in which you have to take the skin, the muscle, the artery, and the vein, and you have to make the microvascular suture of the artery and the vein. As you can see here, we can cover even a great defect of the skin, but again, a long time of surgery, and the critical point of was the artery suture on the artery, so it was not so easy to make this kind of surgery. And then I move to different pedicle flap, like this one is a dorsal bell pedicle flap on the foot, in which you take the skin from the lateral side and you move to the medial side. As we can see here, this is a bell incision on the dorsal aspect of the foot. After the correction of the foot, you have to cover that defect and you move the skin from lateral to medial. Good correction, good option, without the need of free flap, but the problem with the skin was still tight, and so you can make a plasty in a right position that we chose. With the peduncular skin flap, you can cover always all the. Sometimes you have some holes around on the foot. Then I move toward the correction of the bone, and there are different types of correction, like the triple arthrodesis, in which the typical triple arthrodesis, you're going to fix the talonavicular, talocobulate, and talocalcanear joint. Big surgery, and this patient, you always are not good candidate for high demand surgery. Long term of rehabilitation and great amount of stress on the patient. You can use external fixation. Again, with this technique, you can have a good correction, but you need a lot of time. And so you have a problem with non-weight bearing immediately, and a problem, the disadvantages like the decalcification of the bone and intolerance of the patient for the external fixation. Another option, very good option for the very bad deformity, is the tibiocalcaneal arthrodesis and ankle fusion. I always use a nail from the calcaneal, a posterior nail from calcaneal, in which you're going to fix the subtalar and the ankle joints. But it's a big surgeon, good correction, but long consolidation time usually takes 16 months for the complete healing of the bone. Aggressive surgery and a long surgical time, not the ideal candidate in this patient. So little by here, with experience with percutaneous surgery and with the open surgery and reducing the time and the approach of surgical, now I make a different kind of approach to this patient. So let's see all the type of surgical approach. This is a patient with, in which, as I told you before, we have a very bad equinus with no possibility of correction, with just the rehabilitation of some other option. And very important in this patient, you have to make the evaluation of the radiographics, ankle and subtalar joints, and hint for the midfoot to see what happened to the bone, because before correction you have to make and to avoid to have problem to the talus. As we can see here, bad deformity, but not deformity on the bone. First of all, the first step is the percutaneous Achillean lengthening, in which with just 3 posterior incision with a classical technique, we make the correction of the posterior part. With the child, you can correct all the equinus deformity. As we can see here, we just have the deformity of the hindfoot and still a deformity of the equinus. But this is the first step, and we avoid to make a big incision on the posterior part that give you so many problems with the scar. The incision is a small incision. It starts from the medial, for the medial ankle, and go toward the midfoot. It reach the tibial anterior tendon. First of all, we have to make the identification of the posterior tibial tendon. As we have seen in the presentation before, the deformity in the varus is due most of the time the patient to the hyperactivity of the posterior tibial tendon. Just the lengthening of the posterior tibial tendon is not enough. So what I usually make, I completely detach the tendon with a small part of bone from the navicular. As we can see here, is a tibial tendon completely detached with a part of bone from the navicular, and if you need, you can make the long part of insertion with the bone. You can move to the fourth cuneiform. And after that, we have to open the joint. I make a T-shaped incision. I completely open the talonavicular joint, and I'm going to make the arthrotomy of talonavicular. And if you need, a talocalcanear joint too. From the same approach as we can see here, you can see here the approach after the opening of the capsula. These are the joints. This is the navicular, the talus, the calcaneus, and from here we can move to the posterior part of the ankle. We just detach part of the springle ligament and the posterior capsule of the joint. With this procedure, we can correct the residual part of equinus deformity of the foot. From the same approach, we can reach the flexor hallus longus, as we can see here, and we make the tenotomy, and the flexor digitorum longus from the same approach again, and here you see in the deep part the flexor digitorum longus and we make the tenotomy of the flexor digitorum longus. If you still have a retraction of the finger with a percutaneous technique, I make the tenotomy of the flexor digitorum brevis and longus from the plantar aspect of the foot. This is the scalpel that I use for the percutaneous surgery, and with this scalpel, the beaver, we make the fibrotomy, just a small incision to the abductor hallus longus that give a deformity of the foot. And with the same technique, I make the plantar fascia percutaneous release. Then after that, we have to move on the lateral side of the ankle. We have to make the small incision, because most of the time in the bad varus deformity, the talus is subluxated, is medial rotated. And so we have to open the joint with a small opening of the joint right to the ankle and reduce the talus into the ankle. After making all the percutaneous lengthening and just the arthrotomy and the posteromedial capsule opening, we can make the reduction of the foot. And most of the time we can make the complete reduction of the foot. After that, we have to make the reinsertion of the tibial posterior. If we have enough bone, we can make the insertion on the navicular, but most of the time we have to make the reinsertion of the tibial posterior to the capsule. As I told you before, I make the reverse incision of the capsule, so I open the capsule and I put the tendon inside the capsule. So I make the suture of the tendon into the capsule, because you have to correct completely the bone, and the tendon is short, and sometimes you have no tissue to make the reinsertion of the tibial posterior tendon into the bone. And always I make the splat procedure, and it's very useful, the splat procedure, because as we have seen in the presentation before, is a good option for the correction of the normal varus foot. In this very rigid ankle deformity, we use a tendon like the tenodesis effect. So we tighten a lot the lateral band of the tendon we put on the lateral side of the foot while making the correction. The splat procedure avoids the recurrence of the deformity. In some cases in which we don't have the activity of the tibial anterior, or in which the electromyographic, the dynamic electromyographic and the walking patient show that the tibial anterior show no activity, you can use the transfer of the tibial posterior. Instead of make the insertion of the tibial posterior, you move the tibial posterior laterally. But most of the time I use the anterior tibial tendon. This is a clinical results. You can do bilateral, or you can do 1 foot at a time. This is a choice, depending from the patient, from the surgical time. In a deformity like that, I prefer to make 1 foot at a time, because it's more easy to correct the patient, is less painful, and usually you have have to take two surgical time, but sometimes it's best for patient for the correction because it needs a lot of time. And we can see here a video of the patient before she wasn't able to walk because of the deformity, and we can see the foot over the bilateral correction. And this is the result after the surgical procedure. I always make this is a dynamic evidence of the good position of the foot. Most important is some other cases. It depends from the deformity, depends from the type of deformity and illness of the patient. We have to make some other associated procedure. Transfer peroneus longus. As we can see here, the peroneus longus is very useful tendon for tendon transfer, and we must know the activity of the peroneus longus tendon, and always in the neuromuscular disease like the Charcot-Marie-Tooth, one of the causes of the deformity is due to the peroneus longus, because the peroneus longus is an invertor and cavus, it makes the cavus foot. Usually just take off the tendon and I put inside the tendon peroneus longus to the peroneus brevis tendon. This is a patient, a young lady patient with Charcot-Marie-Tooth, and we see after the correction, so after the surgical release, lengthening, arthrotomy, tendon transfer, and we have the peroneus longus to peroneus brevis transfer. You see the good correction of the patient. Other option, in a lot of time you have the varus deformity, you have to correct the hindfoot. So I use a percutaneous calcaneus osteotomy with a small incision just in the medial part of the calcaneus. With the percutaneous, I make this kind of incision. I completely detach the posterior part of the calcaneus. I move laterally and put the two key wire. It's very in this case, you have to make the 4 weeks of the immobilization, but after 4 weeks, the patient start again to walk. You can see here a bad deformity of the foot in the patient, and you can see after all the surgical procedure and the percutaneous calcaneus osteotomy. In some other cases, most of all in patients after traumatic brain injuries, the talus has a bad deformity, and even with an arthrotomy, both medial and laterally, it's difficult to make the complete reduction of the talus. So in this case, I make the small incision on the dorsal aspect of the talus, and I take off a wedge of bone. So as you can see here, after the moving away a wedge, you can correct the talus and you correct the deformities. In some other option, you have the very bad deformity of the foot. The surgical option in this case is a talectomy. Talectomy, that means a complete excision of the talus without arthrodesis. I use the technique most of all in patients that shows a good activity of muscle before surgery. As we can see here, this is a patient with Charcot-Marie-Tooth with a very good activity of dorsiflexion, extension of the finger, but very bad deformity. And in this case, I perform the complete talectomy, in which you don't make the arthrodesis, you don't make the fusion of the ankle, you leave intact the ankle. You need a lot of time of immobilization, but as you can see here, a good result of movement and the preservation of ankle movement. Usually, in the classical procedure, as I showed you before, I don't make any kind of immobility. I just make the cast, but the day after surgery, the patient starts an immediate rehabilitation for weight bearing. In the case of associated procedure, like the osteotomy of the calcaneus, of the wedge osteotomy of the talus, I just use from 2 to 4 weeks of non-weight bearing casting, and after 2 to 4 weeks, an immobilization for again a weight bearing, immediately came weight bearing. We are trying to make we are writing a paper about our experience on the surgical treatment of rigid equinus varus foot deformity. There are very few articles in the literature about this kind of treatment. Some option, maybe this may be the future, some paper and discussing just nowadays about the tarsal fusion for pes equinus deformity, even in the normal equinus varus foot. Because if you fix the foot to the experience of the author, you have the good preposition of the foot that ideal for the walking for the other foot. Maybe this one may be a discussion for the future. Just now, the arthrodesis take too much time to make the weight bearing, weight bearing. Maybe an improvement of stable fixation in the future will combine with info the mid-future will permit a best result with this kind of results. The final outcome, the same in the same presentation that show Mary and Keenan. Maybe in the future we have to talk about the patient. We have to discuss about the long-term studies because we are used to see the patient, to treat the patient, but we must know what happened in the future for the patient. So we must discuss what happened to the patient because, as we know, very difficult patient in which we are used to see the patient in the after bariatric trauma injury with a traumatic type of walking, and after different here, we can really change the life of the patient, but we have to know what happened for the patient. And so we have to need to study much more time. We have to need to long-term result need. Thank you.
Thank you, Paolo. We'll have about 10 minutes of questions. Paolo, if you can just remain here. And as Paolo's here, and then I'll get Marianne, Alberto, Olivier, and team to come up. Do you have any questions for Paolo? Any questions? I have yep, we have a few questions there. Nadine?
I have a question for Dr. Zerbinati. I would like to know what are your indications, in what cases do you perform Dwyer osteotomy, calcaneal osteotomy?
As I show you, I'm not used to make the... you're talking about the Dwyer osteotomy. I used Dwyer osteotomy in the past. Now I make different type of opening wedge osteotomy. I use the Malherbe osteotomy. In the cases in which you don't have a correction of the hind foot with the maneuver, you have the andreasis, or in the cases in which the patient standing on the calcaneus still have a deformity of the talus. You try to put the patient in a weight bearing, hold the foot, and you see what happened to the calcaneus. Then you just make the weight bearing on the calcaneus posterior, and you see what happened to the calcaneus. If you still have the deformity of the calcaneus, you have to make the calcaneus osteotomy. In the past, I was not used to make a lot of calcaneal osteotomy because you need a long time of immobilization. Now that I move toward the percutaneous osteotomy, I use a lot it because it's very easy. You can correct all the deformity, but you don't need a long time of immobilization. So in the Charcot-Marie 2 patient, most of the time I use the osteotomy.
Here, one question.
Bonjour, François va traduire, je parle très mal anglais.
D'abord, je voulais vous remercier. Ensuite, vous n'avez pas l'impression que finalement, plus on fait cette chirurgie, et effectivement, à Garches, on a opéré des milliers et des milliers de patients, on a l'impression qu'on diminue la lourdeur de nos gestes pour plusieurs raisons. La première, c'est qu'on est surpris, en fait, de ce qui peut exister souvent dans l'équilibre musculaire et notamment les antagonistes, qu'on a beaucoup de mal à évoluer. Que deuxièmement, le sujet de la peau et de la tension de la peau est un gros sujet, donc on essaye au maximum d'éviter d'avoir des cicatrices parce qu'on sait, notamment toutes les voies d'abord internes, on a des soucis. Et que troisièmement, les systèmes de percutanés, sous écho, etc., nous permettent de garder des continuités, en tout cas d'être très conservateurs. Donc est-ce que vous n'avez pas l'impression, les uns et les autres, que plus vous avancez dans votre expérience de la neuro-orthopédie, plus vous avez tendance à être moins agressive sur des gestes un peu lourds? Ça n'empêche pas qu'il y a des indications d'arthrodèse. Mais est-ce que vous n'avez pas l'impression de devenir beaucoup plus fin et beaucoup plus limité, non pas dans le nombre de gestes qu'on peut faire sur un pied, mais dans la lourdeur de ces gestes?
Sorry, I'm going to try to translate a little bit because it was a little bit long for me. So the main question of Philippe is that with the time, do you have the feeling that maybe you prefer to make some soft tissue surgery, not bony and joint surgery, which are very heavy surgeries, with the skin problem, with the scars problem, with the bone healing problem and that stuff? And with the time, we in Garches, we tried to do the lighter surgery we can do, because to avoid all this complication and to have another solution with the time, because when you perform a big surgery after, it's difficult to make a second look and to change to make another surgery. So what is your feeling about that? And that's a question of Philippe.
Yes, as I show in my experience, I start 20 years old just with percutaneous, because when I start after my experience with Marianne Keenan, I treat patients with equine varus foot just with percutaneous, lengthening of Achilles, flexor toes and tibial posterior. Then I have some cases with recurrence, so I move toward a big surgeon. Now, with experience of both percutaneous and bone open surgery, I choose. You have to use both the techniques. Most of the time, I start with percutaneous surgery, as you told you, but in different cases, you have to make the bone procedure. It's very light bone procedure, but you have to open the joint and you have the reduction of the joint. If you need to have a result that is a result in that on time, you need to make some opening of the joint.
Yes, sorry, it's exactly what Philippe said, that sometimes you need.
Yes, sometimes you need.
You need to perform a heavy surgery.
I think that it's very important. You must use both tendon transfer and both opening of the joint. You have to use both techniques.
And the second question of Philippe, the real problem is the assessment of the antagonist. And for your technique, for example, Olivier, sometimes you have a very thin varus foot, but sometimes it's a little bit created by the fibularis longus with the pronation of the forefoot, because verticalization of the first metatarsus. And that's very difficult in this kind of foot with a varus deformity, equinus varus deformity, to assess the overactivity of the fibularis longus. So what is the action of you will have with the transfer of the fibularis longus on a spastic patient? But it's really difficult because EMG does not give you the response. So you have to feel, and sometimes that's very, very difficult. For the splat, for example, we put the transfer on the fibularis brevis. You know, the suture is on the fibularis brevis, and after the surgery, the foot sometimes make like this because the fibularis labis is overactive, but we didn't see it before the surgery because it was masked by the deformation. So the assessment before surgery, it's a real big challenge. And I think all these techniques are obviously very good. But what surgery for what patient? I think this is the real point. And the second point, for the long term, I think we have to discuss all together to make a big database. I think all together we will have long-term follow-up for all our patients. And I think it's one of our projects for the future.
Looking for the future, particularly to try to check if we have mini-invasive versus major procedure, we have to try to define something related to stroke patient and when, traumatic brain injury and when, and other disease, because, for example, Paolo presented a lot of nice results in Charcot-Marie-Tooth. Charcot-Marie-Tooth is completely different from stroke patient, the age of the patient, and the neuromuscular pattern of the patient. And when we are doing this, this is a key point, because the feeling from a PMR physician is exactly like Philippe de Normandie, is that in this moment compared to 25 years ago, we need more soft tissues, early treatment than major procedure in stroke patient. Traumatic brain injury is in the middle. Now we open a window related to Charcot-Marie-Tooth or other neurodegenerative disease or genetic disease.
Philippe Marc from Toulouse, perhaps a naive question, but a question for Mrs. Keenan and for our colleagues from Martinique, about what is you minding? Do you think there is an activation of fibularis during swing phase in normal subject? That's my first point. Because if there is no activation of fibularis during swing phase, tibialis anteriors alone, sorry, is not a varus muscle.
That's a lovely question, and I had the same question. When you look at normal gait analysis, and even in spastic patients, it is not a preferred pattern of activation. And you heard in the presentation that they believe the muscle retrain, it switches its pattern, which is an interesting proposal. I don't know if they have enough data to tell us that. I think that what you saw, and it's hard to see in a video, but my sense is that they put the tendon in tension, and it keeps the foot in that position. So it's more a cradle. It's just holding the foot there, a mechanical tension. But if you saw in all of the videos, the knee was always in flexion, and so you saw the movement when the knee was in flexion. Very different than when you're walking. So, but I'll leave the question.
I have no the answer, but I overturn the fibularis longus to anticipate the very often relachment with time, because it's a side-to-side suture. So I have some patients at the beginning of my experience with equal tension. It was also good result. Perhaps I tense too much the fibularis longus, I don't know. But my impression is that we have really a better result concerning restoring active dorsal flexion, because you convert this plantar flexion in a dorsal flexion. But my question is, my difficulties in daily difficulties is to miss the difficulty to diagnose mixed anterior and posterior varus. It's because that sometimes I perform a Dwyer osteotomy in the same time, but perhaps it's better to make to perform a lengthening of the tibial posterior, or a split of tibial posterior. I don't know. What's your advice, Mr. May?
These are such complex patients. I have no experience at all with the transfer of the peroneus longus tendon, but I'm very impressed with your results. What I have seen are some patients that I said had a combination foot, and we did a series of these patients, but they weren't that common, where you would have equinovarus during swing and then valgus during stance. That was not a fixed bony deformity, it was a dynamic deformity. And in that case, it usually was a secondary procedure to then do the peroneus longus transfer to help with the valgus. I don't know if that answers your question. It's, one of the questions I had for Paolo, though, showing some severe fixed deformities and problems with the skin. And even when you're doing percutaneous tenotomy, small incision, capsule releases, you still have problems with tension on the skin. And so in that situation, I think I would be more aggressive with bony procedures, because by shortening the bone, you're relieving much of the soft tissue tension, and getting more relaxation of the skin, so you wouldn't have as much problem. And and I don't think that the osteotomies and fusions are that much more difficult to do technically. And maybe I'm just more aggressive, but I let the patients wipe here immediately in a cast. As much as possible, you have to get on with your rehabilitation, and so.
I have a second question, please, for Mrs. Kinney. You tell us during your talk that if you transfer the tibialis posterior, you have a risk of flat foot. And I ask you if you already observe it, because it's a long discussion with Philippe de Normandie about in between our both team. Why? Because we perform some Watkins with transfer with tibialis and posterior with not so bad result in very impaired patient, really impaired patient, usually with loss of knee flexion. And we have tried to look on our data if they have fat foot. They have no fat foot. They have cavus foot after the transfer. And I think it's the same experience in Lille, where they perform also Watkins. It's clearly described in the literature, but with no real data showing if there is fat foot after a transfer in spastic patient, not in young patient or in peripheral deficiency. But in spastic patient, you have no flat foot after transfer of tibialis posterior. That's my opinion, and we have published it.
I agree with you completely that your immediate results, you don't see a valgus or flat foot deformity. I'm talking about long term. And the first time that I really recognized it was looking at adults with cerebral palsy who had had surgery as a child. And over time, they developed this valgus foot. And so when I raise the possibility of considering a subtalar fusion, I think of it as a prophylactic procedure. If I know that I'm weakening or removing the pull of the tibialis posterior, that making the patient more vulnerable to that problem. Because even just seeing older patients who have problems with degenerative, flat foot deformities, it's a tibialis posterior that is insufficiently functioning. And so that I raised that question for just long term.
Thanks to everyone to share your huge expertise. I'm not a surgeon, so I have some difficulty to understand your cooking technique as a surgeon. I have one question for Olivier and one for you, Marianne. Do you confirm that when you transfer the fibularis longus, you cut a tendon, of course, and you take the proximal part of the distal tendon and you fix it you attach it to the tibialis anterior? So it's a passive tenodesis effect, in fact. It's not an active transfer because it's only the tendon you transfer to the tibialis anterior. It's not the muscles. So you have no active movement. It's passive transfers. That's it?
Yes, it's like the Bardo technique,
yes,
but using peroneus longus.
Okay. So I understand. And my question for Dr. Keenan was, do you transfer sometimes the EHL to the tibialis anterior or only to the bone?
Only to the bone, because I think you can technically get better fixation and have tendon to bone healing rather than tendon to tendon healing, even with the more complex weaving of the tendons together. So it's and with the interference screws, it has made things so much easier for fixation, and you can not only have the patients be weight-bearing immediately, because do that for everyone, but remove the splinting and the casting sooner and begin more active therapy.
Thank you.
To complete my answer, it's a passive anastomosis, but when the patient had a little voluntary contraction of the tibial anterior, the result it's active dorsiflexion.
Okay, of course. And you transfer the distal part of the proximal fibularis longus to the brevis? What do you do with?
No.
You let it go.
Only the peroneus longus.
You let it go.
Yes.
Thank you. Last question, maybe Bertrand, and after that's finished. Sorry, because we have, you have to follow our schedule.
Just to complete with the benefit we had, we convert a muscle that play a role in the plantar flexion in dorsiflexion. So that's why maybe we have a better result.
On the posterior tibialis.
Dans nos patients hypertoniques, il y a souvent l'abducteur qui maintient la voûte. Et effectivement, quand on touche le tibial postérieur, il n'y a pas de conséquences. Alors que dans nos neuromusculaires, ou dans la pathologie qui est la pathologie plus périphérique, on n'a pas cette hypertonie de l'abducteur qui finalement, plus le temps passe, plus je pense qu'il a un rôle clé dans ce soutien de l'arc. Et que l'évaluation du geste du tibial postérieur, il faut le mettre en perspective par rapport à la puissance de l'abducteur du gros orteil. C'est un continuum, il faut réfléchir continuum.
For Philippe, there is a huge difference between spastic patient and CMT, peripheral and neuromuscular patient, because there is a continuum between tibialis posterior and abductor of the hallux, because they are working together. And when you make a tenotomy of the tibialis posterior, there is no flat foot, because this muscle is really a key point, key muscles that maintain, the arch of the foot. And very often we make, some anesthetic block of this muscle, specific anesthetic block of the nerves of these muscles. And you can see that this muscle is a really strong muscle and maintain, the arc, the first arc of the foot. So it's a different way of thinking between these two kinds of patients.
So I may close this session by saying one thing, and that is that the assessment really becomes critical. And although most places do not have access to gait analysis, at this point, it's a very good tool. If you don't have that, then doing diagnostic blocks may be an option, and trying to answer the questions one by one. So that's my point.
Thank you. So, sorry, Bertrand, but we have to just make a quick short, rest, just to have discussion on the terrace. We are going to open the window. This discussion about the equinovarus foot, we will have it during the DILFI method and all the results. So keep your question in mind. I think you will have time to have this discussion later. So we are going to go back at 11 because you have a short time for the lunch, so please respect this. Just one thing. All the physician and surgeon, before the next session, you will have to take this box. Only physician and surgeons, because we are going to make a poll vote for the DELFI of our, and so you need to have this box. You have to keep it up. Laurie will have it, and Salim over there. So only for surgeon and physician. And last thing, I have forgotten one country, because it's a little bit one of my country. I have forgotten Australia. And Jan Bagule is here from Australia. It's a new country. And thank you so much, Jan, for coming from so far and to be with us and to, increase the community of neuroorthopedics. Thank you, Jan.
And thank you to all the speakers, and a round of applause to all the amazing speech and discussions today.